Hi, I hope you are well. This podcast is a place for people to share personal and professional perspectives, talk openly, and ask questions. From serious to silly to sublime, it's all about communication and connection. Always coming from a place of kindness and curiosity, we talk about shared humanity, discuss ideas, and highlight people creating a better world. We've got to keep learning, keep growing, keep being. I'm Melissa Beek, and this is Beek on Being. Today's episode is Beek on Being and Aging Well. When my daughters were little, there was an American Girl doll book called The Care and Keeping of You. Broke down what was going to happen with their bodies, their brains, their emotions, everything as they went through puberty. When I was pregnant with them, there was the holy grail of books. What to expect when you're expecting. Again, a book about what was going to happen to our bodies, our brains, and our emotions as we went through pregnancy. So where is our Aging Well handbook? What are we to expect from our bodies and brains? What do we need to know about the care and keeping of ourselves now? And what can we expect cognitively, physically, and emotionally as we age? Let's break the myths, expose the truth, and bring information to life for all of us because you're getting older now. More responsibility. You've got questions, and these two amazing women here with me today have the answers. So ladies, please introduce yourselves and tell our listeners a little bit about you.
Go, Jamie. Hi, I'm Jamie. I'm an LCSW, which stands for a licensed clinical social worker. And I've been a therapist in private practice for a long time, like 20 some odd years already. And I've done other things as well, intermittently, but throughout, like I said, been in private practice. And I mostly work with individuals ranging from preteen all the way through 65 plus. So
Perfect.
Whole host of issues, age-related issues, and so on.
Perfect.
Hi, I'm Perry, also a young. Jamie's my sister-in-law. And I'm an internal medicine physician here in Miami for the past 23 years in private practice. I'm in solo practice. I take care of predominantly healthy, informed, I should say, individuals from the ages of 18 up to 90. And I've pretty much been working on the care and keeping of those people for the entire duration of my practice.
I love it. And how did you both get into your professions?
Do you want me to go first?
Yeah, you'd be first. You're
Okay.
closer.
Yeah, that's true. Well, I got into the profession of being in private practice pretty much by luck. After I graduated in graduate school, I started working in a psych hospital in New York, which is where I'm from, where I went to grad school. And after a year or so, when I was fully licensed, I knew a lot of the psychiatrists in the hospital. And again, it was a small private hospital. And in conversation with some of the psychiatrists who all had their own private practices, they asked me if I was interested. And I said yes.
Lucky
and
for us.
Right. That was literally how I started.
I love it. And Per?
So my practice is actually the furthest thing away from my training that was done at University of Miami Jackson Memorial in Miami. And I learned or was trained in internal medicine, which was mostly hospital-based. When I went into private practice and left the residency, I went into with an endocrinologist at first, and then I ended up just kind of going out on my own. And the practice kind of corralled from being hospital-based to entirely office-based. Once you do that, I guess, as an internist, it becomes almost like a family practice or a GP.
Yeah.
And so once someone likes you, they send their friend, their sibling, their parent, their child, and it kind of expanded from that.
Good. Lucky for us for that too. So Jamie, what kind of therapy do you practice with your patients?
So I mostly do cognitive behavioral therapy.
Mm-hmm.
I do a little bit of some others that kind of fall kind of in under the umbrella, a little bit of cognitive behavioral therapy. Like there's a little bit of like motivational, a little bit of like short term, sort of like problem solving.
Right.
But for the most part, it's cognitive behavioral therapy.
Okay, great. And can you tell us a little about how your patients come to you, like some of the issues that they're having?
Sure.
Like what are the most prevalent issues?
Well, first we'll start with sort of like how people come to me. So sort of like Perry was saying, the way her practice grows, I get referrals and people find me a lot of different ways. I actually get a lot of word of mouth. I actually have a lot of past clients and current who will refer friends, family, or something. Sometimes that's a conflict. Sometimes it's not.
Right.
But that's actually fairly common. I mean, there's, some like ways to find me online. Then there's like other therapists. So that can have something to do with like how they're coming to me to begin with.
And what are the most prevalent issues that you find that your patients are dealing with?
I mean, super broad, I could definitely say like anxiety, depression, stress, relationship issues, how that manifests for each person. That's where it obviously, is very individual, can look very different. What someone thinks they are presenting with may not actually be what that is, or might not actually be the biggest issue.
Something underlying.
Symptoms can, right. Obviously,
a lot of times.
I was going to say,
may interject.
Yeah, no, I want to know if it crosses over with your patients.
To me, and come in thinking they have a medical condition, and frequently it's biologically based in the psychologic.
Right.
And so I think a lot of patients of mine will seek out someone like Jamie because they are informed, or they learn that this is not a medical problem, that this is more of a bio-emotional, behavioral problem. Right. And that's how they end up probably at a person like Jamie.
So I was going to ask you that, like when a patient comes to you with physical symptomology, but it's because a mental issue, it's sort of manifested in a physical way. So how do you broach that with a patient?
Usually, as an internist and a primary doctor, the obligation is to be fulfilled that I research and make sure they are not physically ill.
Right.
Because clearly, other than probably, and Jamie can speak to this, suicidal thinking, most of these patients are exhibiting some physical symptoms that I can follow and rule out as a more significant or dangerous, potentially dangerous cause of their symptoms.
Right.
Once I feel that we have arrived at a place where I am not concerned for their well-being,
their physical well-being,
then I can say to someone, okay, I think you need to see a therapist.
Right.
And frequently I will refer to Jamie, but being that Jamie's my sister-in-law, I always give a disclaimer and saying, look, some people aren't comfortable, but I want you to know this person is really a wonderful therapist, but I am related to her by marriage.
Right.
So, but I think that we probably overlap in similar populations.
Anxiety,
based on
depression,
chronology,
stress.
Also like the age of the patient or the client, as well as socioeconomically to a certain extent, because you have to be able to have health insurance probably to cover our bills and so forth. But it's interesting because ultimately they really need a lot more time spent on the psychology and the what Jamie's trained in. My work is kind of easy relatively to that. And it usually could be done in 1 or 2 visits, whereas Jamie's tends to be sequential.
So Jamie, then what do you identify your patients like who are suffering from anxiety and depression? How do you identify that with them as far as differentiating from regular life stress? What are some of the simples?
Okay, good question. I have in my head some of the things Perry was saying, so let me shift to
go for that. We can come back to it.
And then I'm going to go back to it.
Okay. Well, some of the symptoms.
For start, okay, so I could definitely go over some of the symptoms, but what I would say is whatever those symptoms are, if they're impacting the person or their life negatively, right? Certainly if they're impacting their functioning, right? But prior to actually affecting their functioning, if whatever the symptoms are affecting them negatively.
Right.
So for example, somebody might go to Perry because they're having stomach problems, right? Because they're having back problems, right? They might go to Perry if they're having headaches, right? Okay, so those are ways that the body holds tension, right? could be like due to stress. And if they go to Perry or another doctor, and, Perry might be able to figure out faster maybe than some other doctors who might say, okay, well, let's try this, let's try that, right? And if those things aren't working,
Right.
then someone might suggest, okay, well, maybe this is actually a different issue.
Right.
A really important one where I would say we do overlap is sleep,
Yeah.
and people with sleep problems, which
Right.
is very common, right? And there are people that know that they're suffering with sleep problems, and then there's people that like don't even realize that that's an issue. So someone might go to Perry saying like, I'm having trouble sleeping. Like,
Or they're
what's wrong?
tired
Right.
and
Right.
they aren't sleeping.
Continual fatigue.
Right. Or disrupted sleep, like either
Right.
having trouble falling asleep or
Staying
staying
asleep.
asleep. Right. Like those are two very important factors that someone might come to me first or might go to Perry.
When does it cross the line from, okay, as you get older, you get up and you pee a couple times in the middle of the night, especially if you're drinking a lot of water before bed. But when does it cross over into something that's disrupting your life?
Well, my first answer would be how you feel the next day and how consecutive that is. Right. So if it's every single night, that's
There's an
going to wear
issue.
on you. Right. Now, if you get up and you go to the bathroom, but you can fall back to sleep relatively easily, like let's say 5 to 10 minutes.
Right.
Okay. Then
It's not
that's
disruptive.
right. Or at least not to me. Like
Right.
that I'm not going to be able to help with. Like if you're getting up that much to pee, you might go to Perry and say, what's going,
So what are the signs and symptoms then, more than normal stress, that you identify as, oh, this person's clearly dealing with anxiety disorder or depression?
So difficulty falling asleep, which many, many people have. Some don't even fully realize it because they're so used to it and they're so normalized to it. Or you can fall asleep, but you
Get up.
wake up and then cannot fall back asleep.
Okay.
So some people can wake up a few times during the night, like they can eventually fall back asleep, but then they'll keep waking up. Like they'll get maybe 2 to 3 hours at a time. That's not enough. So if you wake up 3 times,
You're not sleeping.
no.
Okay.
I think also to answer your question, though, and if you're looking at someone and wondering if they have a distinction, I think this is what Jamie's going to get to, but like, is this something, if it's interfering with their function, how do you make a clinical assessment that this is legitimately something that needs to be addressed or treated, whether it's cognitive
Therapeutically.
behavior
Yeah.
in some way? And there are clinical tools, but also, and amazingly, we haven't really come much farther than this in a sense that when someone has to express their symptoms, you use the word signs, but symptoms, the way I perceive them, are a patient's or a client's subjective experience.
Subjective.
A sign is something that is sort of objectively looked at.
Right.
Okay,
You
so like I am
recognize.
assessing it.
Right.
So when I hear a symptom, when someone tells me they're not sleeping, they can't eat well, or food is bothering them, let's say, they have low energy level, they have maybe a disruption in their interpersonal or sexual relationship. There's a list of them, and if you meet enough criteria, that already
Sure.
is kind of a clinical diagnosis. So when someone comes in and says to me, I don't want to spend too much time on this, but when someone comes in and says all these things, and they're getting up at night and this and that, and they're tired, and they go on, and I'm having stress at work, and they're not even identifying that all these items are
Right.
related. But I'm hearing sleeplessness, fatigue, low energy, difficulty concentrating, sexual relations are affected, and a few more. I'm already thinking this person has nothing physically wrong with them that
Right.
I can treat. This is an emotional,
Right.
behavioral, psychologic issue.
Got it.
And at that point, then I would probably interject for them to be assessed by someone like
A
Jamie.
therapist like Jamie.
Yeah.
Got it. Okay. All right. So,
And on the flip side, I'm sorry, I would say when someone comes with me, and obviously some of in the initial questions that we ask, right,
Assessments,
are there, right, like, what is your medical history? Are there any medical issues, and then those are things right off the bat that, I will ask, where are you at with your medical care?
Okay.
Like has
Right.
that been checked? And then just like, if you were to go to a chiropractor and your back is not any better, the
Right.
chiropractor might say, okay, well then maybe I'm not the right person,
Right.
right? As I go through
Got it.
with my patient, I'll be like, well, have you checked in with your doctor about X, Y, or Z?
Got it.
Right.
All right, got it. Because I was thinking, how does someone identify them themselves if they're not recognizing it as a mental health issue and it's manifesting as a physical issue? How does someone identify it themselves? But clearly, if they're getting their regular checkups, one of you can recognize that it's one or the other. Okay, great.
And you have to be complete. I'm just going to say, obviously, not just because of medical legal issues, but from my side of things, when someone has headaches, you're not going to ignore that they have headaches. I would pursue a small workup. But if I started recognizing that everything is looking like it's nothing,
right,
then
after
I have
diagnostics
to think about
and stuff.
why.
That's right. Got it. Okay, so how do you therapeutically help them tackle the emotional and cognitive behavioral aspects of all of this?
Well, that's a big question.
Okay.
Yeah, right.
Well, once the patient's left Carrie's office, now you've got the big job.
Okay, well, so I'll answer that super broad first.
Okay,
because I would say obviously
it's
it depends
individually,
on the age. Right.
exactly.
Well, it's individually, but depends on the age, So professionally speaking, the person has to feel comfortable, right? They have to want to come back. Okay. They're under 18. I'll go with that's a little different, but speaking for 18 and above, honestly, like the relationship is really what like matters the most, So like I said, like the person has to want to come back, like even when they don't really feel like it.
Right. They have to connect with you.
Yeah.
Okay.
Yeah. And be willing to be a little bit uncomfortable.
Right.
So that's my very broad answer.
Okay, well said. I'm going to go over this again, but it's important to pay attention to the cognitive, physical, and emotional changes that we go through as we age. Normal changes are mild and manageable, whereas abnormal changes are progressive and interfere with daily life. So I want to break down what we should expect and when we should be concerned in the care and keeping of ourselves as we mature. So in both of your practices, what are you seeing as standard health issues as we age outside of like depression and anxiety? What are the normal or typical aging issues?
So I had to do a little research on this.
Oh, okay. I like research.
Because I did.
Outside of depression and anxiety, I mean.
In general, it's important to acknowledge that if we want to talk about aging, it's not just a concept, it's a physical change. And that does portend or apply to every different area. And this was what I was intrigued because I haven't really studied geriatrics or aging in a long time.
Well, we're getting there with you, so
that's right. So
don't worry.
But it was interesting because a patient came in to me and she told me she's in her mid 70s, and she told me it was really relevant to this topic. She said, my daughter was with me over the holidays and she thinks I'm very slow. In every way, I have slowed down.
Like physically,
mentally, everything. Now, this woman is still working 3 times a week. She still exercises. She's active. She's kind of like our moms. So we're very lucky, by the way, 2 listeners out there. We have very knockwood, pretty functionally healthy moms. But so it made me curious as to what did I learn about and what has changed? What is aging?
Right.
And when you look at the aging, there's different components of slowing down. I mean, they're really specific, but they also are broad. And so it looked at physical function, they look at cognitive, they look at emotional well-being, and they look at social engagement.
Right.
And part of it is preserving independence. So when they looking at the physical and the actual neurologic and I guess body systems approach, I mean, your esophagus slows down when you swallow. Right. People are coughing or choking or having more postnasal drip. That's because we don't have the same clearance of our mucus.
Right.
Joints. Our GI tract slows down. The urinary bladder changes. Obviously we know about, you might want to get there after, but menopause is clearly the most blatant.
Yeah, that's later on.
Stopping of systems where women no longer have eggs in their ovaries. But in general, everything is a slowing down. Your gait changes, the ability to perceive our body in space changes, our vision changes. That starts at 40. You start to need reading glasses. By 44, only a couple people at the table need reading glasses for dinner. By 50, everyone borrows each other's. hearing changes. So all of these processes begin to slow down. And that's very important because that's natural.
Right.
And there may be some things that can stave that off. And there's a lot of talk about mitochondria and different
Right.
things that could make us live longer and slow down your aging. But in general, I mean, this is a process of every body.
Yeah.
And so it's hard to kind of stop that.
Right.
And the key thing when you look at aging, which is what I was going back to in my training, is how do you give someone a really good quality of life as they are aging? And that is at every stage, because there's the 30s, the 40s, the 50s, going into, as I said, the 70s or the 90s. Is this person independent? Can they, and this is something that really in a background in social work, Jamie could definitely remember from her training, which are the activities of daily living and the other activities of daily living. So the things like, can you feed yourself versus can you do your banking?
Right.
And so there's so many assessments that we do as people get older to determine if they're impaired in any way or if they're not. But I think that's like a very broad picture.
Right.
And it speaks to also, we tend to, people tend to say, I was reading that there's a lot of things, this is called pseudo dementia, but people get depressed as they're older. Is that normal? And actually it's not.
Right.
It's not normal to be depressed, but it's normal to have a slower cognitive response time and recall. And that all begins in your 50s.
Right.
So I think to speaking to emotional well-being, which Jamie is trying to craft, if she were caring for older people, she's still worried about kind of the same things, but
Quality
may have
of
to
life.
approach them in a different way.
Right. So I was going to ask about that with quality of life and like a certain amount of decline in executive functioning to be expected.
For sure.
Okay.
But you want to observe what I think Jamie could probably explain executive function better. But, the first thing that I think of with executive function is like working memory and how you can bring other thoughts forward.
Right.
And immediately, I think it starts probably in your 40s, really,
think
where
so.
you start to have recall where you don't remember someone's name and the name's on the tip of the tongue. And that's all really normal. But that can progress into something else. That's normal senescence, as we call it, or like changing in the biochemistry in the brain.
No, I've never been able to remember a name. I can recall every song and
Or
know
a
everything.
scent.
So if that declines, that's my warning sign. Like,
Well, that's
the name,
true.
no, but the music and the dances, I could
or
do
your
that.
muscle memory.
Yeah,
Right. So that your memory of where you're going in space from a song.
So when do we get concerned that it's not just I came into the kitchen or I forgot where I left my readers or whatever, or there is dementia or Alzheimer's or some sort of cognitive disability or decline happening? When do we get
do you
concerned?
want me to answer that? Because
Well, I mean, I actually can, but you're
You
better
answer.
qualified to answer.
No,
it.
No.
You
Jane,
answer.
I want you both to
Yeah.
answer.
Okay. Well, I can answer that not so much because of my work and my practice, but from my much earlier work in the psych hospital. 'Cause I
Right.
actually worked on the geriatric unit in
right.
the dementia unit. So I can speak more about that part, not quite so much like
No, that's okay.
the in between, if
Right.
you will.
So take us from
So
normal
again, when
to
it impacts
concerning.
someone's daily functioning,
Okay.
like their ability to care for themselves,
Okay,
and to
but-
go through their day.
The 20-year-old is going to have a different daily functioning than an 80-year-old. So yes, as we age, we're not going to be as spry or as all the things that Perry said about our ability to do things. But when is it concerning, oh, okay, well, yeah, I can still pay my bills and I can still do this, but there's certain things that I'm forgetting little by little each day, that there's a decline.
the first sign that you just said is I'm forgetting.
Right.
That is the number
That's
one
it.
thing that's the least important.
Okay.
The most,
It
the
usually
most,
doesn't come from the person themselves. It comes from the people
Somebody
around them.
else.
the most critical piece of the story is understanding understanding where you are in relation to others, why you're there, and how it's supposed to work.
The
Not
self-awareness,
details.
Okay.
The person who is starting to exhibit
cognitive changes.
mild cognitive impairment, and this
Right.
was I looked this up too for you because
I like it.
the answer was about 15 to 20% of adults have mild cognitive impairment. This is a very
And
important
that's
thing.
natural or no?
That's not natural.
Okay.
So there's senile aging loss, which is just all these things like tip of the tongue phenomenon we were talking
Right.
about. There's what Jamie's sort of also mentioning too, which is like, are you starting to slow your function versus are you not functioning? There's
Got
a
it.
difference. And then there's this freeze area of mild cognitive impairment where people are starting to develop or show signs of possible some memory loss that would be significant.
Got it.
Not memory loss that they're necessarily noticing. They could be noticed. It's usually noticed by others.
I was going to say family
Those
or
around them,
friends.
right? Those around them.
And that's a very pivotal piece
That's
of
telling.
the story.
Yeah.
And so that's a sign that this person should be assessed when someone is recognizing they're not making sense, they're suggesting different timeline of story. They forget answers to things that they were just recently asked.
Or repeating.
Not even repeating. They do start to repeat themselves, but that's usually not in mild cognitive impairment. It's usually flipping like a number.
Got it.
Like just a small shift in the information. That's
what their living situation looks like, how they're taking care of everything around them.
right. Just
Okay.
small details. Like they lose their sense of direction all of a sudden. And it's a person that always knew where they were going confident.
Okay, again,
driving.
so it really depends on friends and family members to
Correct.
recognize these
and
differences.
then those people should be in some way assessed, probably by a neurologist, but initially by a doctor, to see if there's anything else underlying that. Because of that population, this is what I was looking at for you, about within 1 year, 10 to 15% could develop actual dementia. And there's a whole subset of dementia. That doesn't mean Alzheimer type. So if
Right,
you're talking about cognitive decline, the idea I think that you're looking for is capturing these people who are sort of making small mistakes
Got it.
to pick up who of those people might actually be developing something that we're missing.
Okay.
And usually the first thing that I hear and I'm sure Jamie can really talk about this, because there's a big distinction of like attention and focus, ability to recall. And this occurs even
Concentrating.
in our younger population. They're very aware of this because everyone has ADHD and everyone is worried that they might have ADHD and they're being told that they do. And there's a reason they could.
Right.
But when you're 50, if you haven't found yourself already knowing that was sort of an issue, you mentioned, and I want Jamie to explain what executive function really is.
Right.
But I feel like you would start to ask these people questions about, are you really remembering this, or are you too distracted to remember it? And this also, I believe, lays into anxiety, because people who have anxiety have an ability to organize their thinking.
Got it.
So from really a therapy or Jamie's standpoint, and she could talk about what executive function is, because I think that you lose executive function as you get older in general.
Right.
But I mean, most people don't decline into not being able to care for themselves in their own house until later stages.
Right.
I think you're looking at little nuances that Jamie could say, this is a concern, or this is poor executive function at
Okay.
different ages. Right, Jamie? Or,
Yeah. Okay, so I can pick up right there, basically. So, I mean, what did you say before? When you think of executive function, you think, recall. That's what it was. Okay.
oh, yeah. Like you,
Oh, yeah.
Yes,
Recall.
Right.
But that's
See?
a
There,
perfect
exactly.
example. Was Jamie able to exercise her ability to say,
Recall.
where was I in that conversation?
Right.
And recognize she didn't know where it was and she was going to go back to it.
Right.
Got it.
And get it back.
To retain, right. to
Yay, you.
No, but Jamie, to retain it,
Yeah.
to remember you did retain it and try to retrieve it.
And she
Right.
did.
Right. Which is one aspect. So here, I just pulled it up. Look, I mean, everybody else can't see, but I have like a cute little thing. So I just have it here, like on my phone. So it's different mental processes for planning, organization, and self-regulation. So I like to say that it's different aspects of using your brain to help you basically complete tasks, meaning like you have to think about the task, you have to organize the task, you have to do the task, right? So like everything that encompasses that process. So that includes planning, organization, like I said, self-regulation, and that's reflected in where is the success? Is it in behavioral success? Is it in academic success? Is it in life success, which obviously is going to pertain to our different age groups, right?
Right.
Like, so what does that mean at 20? What does that mean at 40? What does that mean at 60? What does that mean at 80?
80, yeah.
Right? Different things with different expectations as
Right.
well. I wanted to say something about the factors of aging. One of the things that people come to me a lot. Like, so Perry's talking about the, physical and medical aspects of aging. But another big one is on the outside, the effects of aging, right?
Right.
Like our skin changes, our hair changes, right? Our weight may go up, may go, go down. Like our bodies start to look
I have a
different,
whole set of questions
right?
of that coming up.
And, oops.
Can you hear me?
Yes. Okay, now I can. And so that is something, and of course, menopause.
Yeah, we're getting there too.
When someone will reach out to me when they are really struggling with those changes.
Okay.
That's pretty common.
Okay. Per, as a primary care physician, can you speak to your role in maintaining overall health and what your patients are experiencing as they age? Like,
Sure.
you already discussed slower metabolism, muscle loss, bone density, those kind of things, but can you break down normal aging for someone who's 50 plus?
I think that at every stage, the way I look at, there's definitely a chronology or an associated, not just to look at aging, because I think I have to speak about younger.
Right.
At every age, when you take your kids to the pediatrician or anyone who's ever, they have
There's
something called
markers.
anticipatory guidance, right? This is telling you about what is coming up in your next little while. Should you cover the outlets? Yeah, 9 months, you better start.
Yeah.
But they don't tell you at 12 months when the baby's walking. They tell you before that to let you know. So in adult care, there's the same kind of reality. Like when I speak to a woman who is in her 20s, we might talk about, not just her current relationship, but potential for fertility or
freezing the
these are
eggs.
some things. That's right.
That's
like
something that
egg freezing. So there's something that we have to talk about, not just her anxiety or her school or work, but we talk about physically
What's coming up.
What is important at this age. And that kind of leads in every, not necessarily decade, but every 5 years or so, because there's certain hallmarks of care that need to be implemented at each period. And I think it's really interesting because today people have a lot more access with the internet and AI to finding out what they should be looking for. And sometimes they're looking for it earlier. And I have to sort of bring them back and be like, you do not need to worry about that.
You're too far
right
down
now.
the line.
You don't have to worry about your cholesterol, or you don't have to, we're not worried about this number. Let's focus on what's important in these next 3 to 5 years. And so I think as we get older, what patients will mostly complain of, like the woman that did come in, she wasn't really complaining. She was just noticing, her daughter noticed a difference. And I think the key pivotal thing of that is when you're older, you definitely start to have, as Jamie said, hair thinning, skin changes, visual changes, and just in general, maybe your stamina is not exactly the same. Like you could be in excellent physical shape and have great stamina, but you do notice that from 3 to 4 to 5 to 7 years earlier, wow, you were really lifting great weights, but now it's just so tiring and you don't have the energy. So people will worry about that. I feel that they're worried that that is a sign of something worse.
Of declining.
More than, not even declining, just, is that acceptable, or do I have something wrong with my heart? What am I not doing?
Yeah, I was going to ask you that. Like, what are the risk factors that we should know about our immune system, our heart health,
right? Because
bone
your immune
density
system gets worse when you're older too.
Right,
Your bone density is worse. I mean, it could be depressing. We could soon all be seeing Jamie, but in a sense, it's more like, how do I maximize?
Yeah.
I mean, I feel like people are so focused on aging and longevity, but I feel like, how do you maximize?
But I want to also talk about prevention. Like, how do we stay healthy? What should we be doing to take care of our bodies to prevent?
The 3 things, honestly, that you need to stay healthy are no cigarette smoking, minimal to no alcohol consumption. That is the number one adverse thing for the brain at any age. So any young person who is drinking, if someone said to me, what do you tell a 20 or 30-year-old, or stop alcohol? That is the number one thing that's going to shorten your lifespan. And leads, obviously, at the early stage, leads to
just
accidents.
Mess you up.
Right. Just, it's not good.
Right.
So, but I think that in terms of staying healthy, I think the cardinal things still apply, because
Don't drink, don't smoke.
In
moderation
every study,
with
Move your body,
food,
like
move your body,
like, get social
exercising,
interaction,
social interaction, yeah.
sleep regular hours at night.
Right. Eat a Mediterranean-based diet and a low-salt diet. I mean, keep your muscle mass up. Use your brain in a productive way and a rewarding way, which is, I think, so how does someone stay present? And I feel like Jamie, one thing I really like, I mean, this is not just because she's my sister-in-law, but because when I hear what Jamie has told clients, I feel like, oh my God, that's brilliant. Now, maybe it's not so brilliant, Jamie, but it is so
we love
on
her.
target.
She is brilliant.
No, some therapists really can connect and hone in on what the pivotal and crux of the matter is. And Jamie, I feel more so than I, because I'm not, Jamie's very direct about that.
Yes.
But I feel you are, right, Jamie?
Yes.
Sometimes to a point where a client has to accept that.
Yes.
And,
but I appreciate that. I think that's fabulous.
The key message would be to most people exactly what Jamie's saying. If you want to, now everyone says, well, how do I reduce? The one factor we don't know about is stress. Where does stress, external
I think
stress,
it's a killer
internal
for everything.
stress, really makes everything complicated and does age people. So the point is having, whether it is a Jamie in your life or it is the outlet that you can find, and you always have mentioned dance as one of yours, and your art and your reading.
Puzzles and my books.
Puzzles,
And,
that's right.
Right. So it's your care and keeping of you. It's your, what is your self-care?
Right.
Like,
It's an individual
it's not
thing,
just your
'cause
care in
I am
terms of
not a
going to your
social
doctor's
person.
appointments.
You are
that's-
my people I socialize with.
But it's the
I
self-care. It's
yeah.
what are the things that each of us does that like
benefits
we enjoy,
ourselves, that we enjoy,
right.
that
and
we
that we
take.
know when to use them.
Right.
Right. See, stress itself is actually not necessarily a problem. It's
Right.
not always a problem. I talk about this all the time.
But it's how we
I talk
manage
about
it.
stress management skills exactly, and what I tell
also
everybody.
some stress is adaptive, and it actually is. I mean, a
Correct.
deadline could motivate you.
Right.
It's when you
Correct.
when
And
you
also
haven't-
some of it's a learning experience, because
100%.
sometimes you get thrown into a lot of things and you're just sort of treading water, but then you learn to manage
Part of
better and to
resilience.
function better, be
100%.
more resilient. So
100%.
I
So
think
I
it's how
say
you
to
address
everybody
it.
is that stress management is not stress reduction.
Right.
You don't necessarily need to be less stressed. Like obviously there are many people that need
Right.
to be less stressed.
Right.
But the point of stress management is learning how to manage the stress
Your
that
stress.
you do have.
Right.
What makes you feel better? What helps? What do you need? How do you help yourself?
Right.
How do you ask for help?
Right.
Whether it's then looking for me, whether it's then talking to your friend, what is it you need? Whether it's like retreating for a few
Right.
days. Those are the
Recharging
It's
types of
also
your
things.
being your
battery.
own best advocate too, because I
Absolutely.
think you need to know yourself and your norms and what works for you.
and then make some boundaries that
Right.
aren't harsh or cold,
100%.
that give you
No,
the
thank
time
you.
to heal.
Full sentence.
Right.
That's right.
Right. But these are the things that then people are coming to me because they're struggling with exactly that. They can't
Right.
they can't identify that in so many words.
Right.
But that's exactly the stuff that then we're working on.
Okay. So when should we hear alarm bells? If something's happening and it's not normal stress and it's not normal aging, when do we get concerned with our heart or our brain, or like what's something that we say, oh, we need to go see a doctor immediately, like ASAP? What's a warning sign?
I mean, for me, clinically, the warning signs they're like the danger situation, and then everything else is pretty manageable. But the danger situation would be like a mass in your breast.
Right.
I mean, I know this is like obvious.
So what
but
diagnostics, like what blood tests, what should we do for ourselves annually? What sort of physical and cognitive exams should we be having?
pretty straightforward. I mean, really just you need a blood pressure check. You need to have your labs done, routine labs. You do not need 900 blood tests. You need about 5. You need a blood count that tells your hemoglobin and your white blood cell count. You need chemistry, which includes your liver and kidney function, probably gives you enough information. Generally a thyroid
I was
screen
just gonna
every
say,
couple
yeah.
of years. But I mean, people who have real thyroid disease, this isn't like a subtle finding. Like people come in and ask me, oh, it must be my thyroid. I mean, generally speaking, people that are sick from thyroid, it
It's
pretty
not
much
found that
shows
way.
up.
They're not functioning.
Right. It's not
It's
found
pretty
that
much
way.
shows up.
Yeah, you're not functioning.
So
that
and
controls
then
everything.
Obviously, you need cholesterol check because there are familial high cholesterol levels which are dangerous and can be lethal at a young age.
Right, for your heart.
Once that's established, then you'll know how to follow that person.
Maintenance.
Either they have that or they don't have that, and then we can determine when treatment is appropriate.
Okay.
And then
mammograms
really at age 40. I mean, I think you can go overboard with the amount of care that we're seeing currently, but I guess the end game is prevention, or at least early detection.
Right. Key.
And then from there, obviously, colon cancer is something we can screen for. Cervical cancer, we can screen for. Most of these things, I'm losing. Sorry.
I can hear you now. Go ahead.
Yeah.
Most of these things we have established guidelines for. We don't tend to do cardiovascular screenings until people are older, because that's a chronicity. But if you had risk factors like a person that was sick early in your family, parents, before 45 or 55, someone who had an early stroke. So I think those things are a little more quickly assessed.
So it's good to know your genealogy as well, because what happens if a person has breast cancer or tests positive for BRCA or has colon, rectal? Should their children be seen when? 10 years younger than the age?
That's changing depending on what that's a kind of if you had certain genes, because of the prevalence of those genes and the likelihood of developing cancer, then that would be quite a bit earlier. If you have, there's a lot of genetic testing out there that reflects a value called a variant of unknown significance, because we don't know the impact of that gene. And those people would probably have less frequent screenings. So, but almost everyone with BRCA genes, or something called Lynch syndrome, which is a colon and breast cancer syndrome, they tend not to be screened till about really 35. So it's not as young as we think.
Okay.
We're only really supposed to pick up these things around 25 or 10 years before that family member was diagnosed.
Got it.
So we have a lot of things, that are on the forefront of how we're going to do good screening, but most of our screening's been pretty well established. You mentioned something about warning signs, and I was going to get back to that, because for me, a warning sign is something that is an imminent danger to the person. I think that is the same as for Jamie, because she'll have warning signs too.
Yeah.
Where we're definitely worried this person is going to need a hospital soon, or some kind of, they're in danger physically. So for me, that would be someone that's having a progressive chest discomfort, shortness of breath. We call this word diaphoresis. It's a technical term for cold sweats. And someone who has notably had to stop their exercise. Someone that goes from functioning pretty well to all of a sudden they can't do the same thing. That person I'm sending to the hospital. Someone who has, we call it a thunderclap or a lightning thunderclap headache, spike headache in the back of their head. They are going to the ER. So there's certain things that I'm like immediately like, I can't see you for that. Fever's over 102 for 5 days. I mean, those are warning symptoms.
Right.
But it depends it could be something very treatable, but needs to be
right. We're not waiting on it
emergently.
Right.
Other warning signs, though, that are like more subtle, they're very varied and would depend on the body system. But I mean,
I feel like women ignore so much of what's going on with their bodies because they're paying attention to everybody else or dismissing it as aging.
Well,
too many things get normalized too.
Yeah.
I think that people don't know, they're not sure, then they get nervous about a symptom and they focus on that. And that symptom may be not relevant to what the problem is, or there's other people who just they're not really in tune with their body, and therefore they are denying. Oh my God.
That's okay. It was a good song.
That's my dad.
I'll say something.
Yeah, go ahead.
Just because Perry started to say that about not being in tune with your body.
Right.
And I mean, for me, there's other things that I could say to answer some of this as well. But one of the number one things is like, you know yourself the best.
Right.
If you feel that something is off, whether mentally, emotionally, physically, right? Like just as you said, learning how to be your own advocate. If you feel like something is off, then you validate yourself to go and ask for help.
Right.
Right. Now, if you go to the doctor 10 times for the same thing and that doctor says this is not what it is, okay, that's a different story.
That's a different situation.
But that does require being in tune with yourself, with your own body. And yes, many of us are busy, whether man, woman, whatever, whether you're aware of it, you're not aware of it. But we all start to notice when something feels off, right? Maybe the first time, maybe you brush it off, second, third, but it starts.
It's loud
right?
enough, yeah.
Right. And so that's when to, like I said, really be in tune with yourself and say, you know what, I don't think this is right. And obviously, like when you're 20, you're not, you
Different.
might not, different. But as you get older and you see your friends, your family, other people around you, maybe going through some of the same things,
Right.
then that awareness really starts to creep in.
So you talk about that and you talk about different ages and things, knowing your body. When you go through menopause, your body does a complete change. It's a new getting to know yourself. You're adjusting to the changes that are happening. What should we know about with menopause and how to deal with things physically and cognitively, emotionally?
Do you want me to go first?
Sure.
Yeah, like what's the effect of menopause on our mental and physical health?
Well, everybody's different,
Right.
so some people don't feel much,
True.
and other people feel some, other people feel a lot. What has been, coming up in my practice with the people that I work with.
Is it normal for mental health issues to increase once someone goes through menopause?
For a lot of people, yes. I think there's a few reasons for that. I mean, the hormones definitely play a role, right? Some of the other symptoms, right? Like disrupted sleep. That's one, right now. Do the hormones have something to do with that? Yes. But obviously, if you're going to have disrupted sleep, that is going to affect everything, right? So that's one of those scenarios where it's like, okay, well, what is going on here? We need to get everything checked out, check all the boxes and all the categories. Some people really struggle with all of that, whereas not everyone does.
Right.
For some women, the ways in which they have coped with things throughout their lives is suddenly looking different.
Yeah.
Right. So if some of that executive
so well said,
functioning is changing, that can cause so much stress. So yes, menopause may be like
The catalyst.
But it's what else is sort of there or underlying. And
Again,
I hear a
learning to
lot
manage.
of people talking about, not just in my practice, but in others, for a lot of women with ADHD, how difficult menopause is. It may have been well managed, medication, non-medication, whatever the case may be, but with all of the changes, that really exacerbates it. And then that's what the women are struggling with. And it doesn't look familiar and it doesn't feel familiar. So then they're not sure how to help themselves with it.
Got it.
I also would speak to that the problem is estrogen is a mediator in this
Good word.
story. It's
I like how you put that.
No, it's a modifier or a
Yeah,
mediator.
it's
doesn't. It's not the only thing. Estrogen and progesterone are not the only things that regulate everything that's going on, but they're there. And so historically, when there was a time that we couldn't treat women with hormones, it was the studies were suggesting that was really dangerous. And so women were using, or most gynecologists were using an antidepressant to sort of treat women through menopause, saying this would remediate their hot flashes and so forth. And it's really interesting because
What does science say about HRT now?
I'll get there. So essentially it's like, I remember everyone when I went into practice was put on Effexor. It's venlafaxine. It's an antidepressant. And it does have something to do with your body's release of, I guess, your autonomic nervous system to cause you to sweat or not to sweat. Ironically, we also found it causes you to sweat. So I don't know how helpful that was. But where it did help women in menopause is it subdued some of their mood disturbance and their anxiety and their brain fog changes at that time. But they didn't stop sweating. And there were other changes that happened that had nothing to do with the effects or medication. I mean, if their skin changed, their bone density, all these things changed. And that was from not having estrogen. At the same time, now that they've changed the guidelines a little bit and softened them and taken away some warnings that the large WHI, Women's Health Initiative study, which was done in the late 90s and to 2000, said, oh, this is a very high risk of breast cancer in women over 65 who've been treated with hormone replacement, specifically estrogen and progesterone. So that study hasn't been entirely reversed, but it's been refuted or modified to understand that we may have given higher dose hormones to people for longer and maybe women who should have been screened better for the hormones. And now it's really acceptable and good practice to use hormone replacement in women who are going through menopause, depending on why we're giving it.
Who cannot use it.
More than that, depending on what they're complaining of. Because to Jamie's point, if someone isn't real, we don't have to medicate everyone who went through menopause. But if someone is experiencing a very big change in what they sense in themselves, not just the hot flashes, but maybe their mood and maybe their sleep and all these different pieces, then this might be a good woman to use hormone replacement in.
Got it.
To maybe support her cognitive function, to give her some extra chance for her bone density, and maybe some sense of well-being that the hormones would give her.
And menopause also for many women is occurring when there's other life changes happening as well, like whether
Kids
it's
moving
kids,
out,
right?
graduating.
Kids moving out, right? Maybe it's the first one, maybe it's the last one, right? Even if you have 4 kids, but it's the last one leaving, that is a big change. Right. And then on top of that, you're going through your own physical changes, right? That's a lot. So I see a lot of that as well. So again, the menopause is just one factor.
Right. I was going to say menopause is one factor, and you said something about mood, and I'm thinking mood, okay, maybe with some menopause things, but also I think you get to a certain point of life where you decide, I don't give an F anymore. I'm not going to be a people pleaser. I'm not going to tolerate this. And you sort of learn yourself and your boundaries. So it's not like a menopause mood, so to speak, but at a certain point you just decide, yeah, I'm no longer tolerating that.
Well, but that's the ability to regulate your own mood.
Right.
See, if you're cranky, you can be cranky. I might not like you, but you could be cranky, right? But you can choose and help regulate yourself. Whereas when we're talking about mood and women that are suffering,
it's not being controlled.
They're really having trouble regulating themselves. They're unhappy with it.
I also find
sorry, go ahead.
No, but I also find that when women, if they're in their years when they had a period, let's say that, when they were menstruating, if they had a lot of mood disturbance around their menstrual cycle, then these women tend to be more susceptible or likely to
mood
have
extremes.
the same problems that are exacerbated when they lose the estrogen.
Got it.
So
Agreed.
I feel that women that weren't as somatic around their cycle, which is a real entity, it's not a made up one.
No, it's not
Some
psychosomatic.
Women
It's real.
Very pronounced premenstrual syndrome or even dysphoric disorder. And so when we're now taking away one of the driving factors for that and totally altering that, biochemically, they're missing part of how they manage things.
Right.
But what I also wanted to say about this, in general with menopause is just that estrogen doesn't cure everything. Right. Progesterone doesn't cure everything, because we'll put people on this, women on this, and some of their symptoms are remediated, but some still remain. And I don't know. It's hard to say.
Yeah, you can't
why.
cover all. Yeah,
it's not a Band-Aid for everything. It's definitely a good mitigator of some of the symptoms.
Right.
And maybe many women, the idea would be just to make them feel a little more comfortable in their own skin, during that time, and then at that point in time reassess. Because maybe the critical life changes that went temporarily matched up with menopause are passing.
Yeah.
But yeah, I mean, it pretty much does suck to feel aggravated, hot, sweaty, and then like your kid is leaving the house. I mean, I really empathize with that. Or whatever. Or you have a teenager and you just want to tell them to shut up. And they're mean and they don't care about you and no one has your back.
They need to go have their own handbook.
Well, I feel like as a woman in general, when I listen to what women do, I mean, sorry to the men everywhere, but like when I listen to what they have to go through and what they have to face and what's on their plate, and
we juggle a lot more,
and how they perceive it, because they're so invested, and many women do have a family or a significant other or a sick parent or maybe
On
a
top
messed
of
up
work
kid
and their own life,
and they're
and
still trying to produce
balance and everything.
So
Or
I
now they
feel-
are caregiving for older parents too.
yeah,
Well,
and
it's that in-betweeners. You have,
So-
you're raising children and you're taking care of your elder parents.
some don't even have children and they have so much on their plate anyway, and they're just trying to survive.
Right.
So, it's funny. I remember this not terrible, I shouldn't say that, but what is a Stranger Among Us? What was the movie with Melanie Griffith?
Oh my God.
And I
yes.
love that
Among
movie
Us.
for
Yeah.
some weird
Yeah,
reason
yeah,
that
yeah.
she was like,
Stranger
but I
Among Us.
remember though, women, God counts the tears of women. And it was a very meaningful thing because I always it is in Kabbalah and I read
Right.
it after
Right.
it was true, but it's something very important to say, like, a woman may have to sustain so many things in her life in a
Right.
different way than a man does. So I feel like no wonder menopause is like annoying
Yeah.
and unfair. That's
Yeah.
what I'll say. And unfair because you're just trying to
Right,
you
you've reached
actually
a
think
point,
you know
yeah.
yourself. And then your body just turns on you.
Yeah,
Right.
that's it.
And I say that having had menopause like a long time ago, and
Right.
I was not given hormones because of the timing, but I do understand that it did change me.
Right.
So I'm just too late to get it now.
There's another thing with menopause. It's a huge, huge topic always, but now there's treatments, weight gain. And I know so many people are talking about, Ozempic or other treatments. Can you speak to that?
Yeah, I'll just be super brief on that because
Okay.
it's one thing. Menopause, there is weight gain associated with menopause. There's something called, as we get older, there's a loss of muscle mass. This is the big difference. And that's a natural part of our aging, going back to that. And so in menopause, it's a time in women's metabolism where they have a much bigger change or drop off of their muscle mass. So for some reason, that's like a pivotal point. It's actually a pivotal point where we see increased heart disease, we see increased medical problems after menopause. So probably estrogen did mitigate, it didn't necessarily protect, but may have had a little boundary against some disease processes that tend to affect men earlier. Even, so with that being said, weight gain and menopause is very common because it's a big stoppage
Right.
in our balance of muscle mass to fat, to adipose tissue. So these medications, the
Yeah, the GLP-1s. Uh-huh.
they are really kind of miraculous in a sense in their ability to target our adipose tissue and the way our bodies process adipose tissue. So in menopause, they're very beneficial because this is many women's big change in their fat to muscle mass. And so this is the one thing, because estrogen is not a weight loss medicine. If you go on estrogen, it may be chronology we don't really understand, but even on hormone replacement, women will still put on weight. So
Are GLP-1s safe?
GLP-1s are going to be probably the standard of care for weight loss in general. And they're just, coming out with more options. But yeah, there's some caveats to that. One is we found a dangerous one, which is a visual loss that happens on people on semaglutide, which is Ozempic or Wegovy. And they think it can also happen with Mounjaro, which is tirzepatide or
What
Zepbound.
happens? Vision loss?
There's an actual retinal vein, basically of an artery or venous occlusion that happens. It's very rare, but it can happen. So you can lose vision from it. So it's a question really for people it's very rare, but it's for people who have eye issues to begin with, macular degeneration, or perhaps had high blood pressure and have some arterial changes in the eye. So it's something I always ask patients before starting.
What if they don't even know?
Well, it's an idiosyncratic problem. So I mean, it's a
pretty
gamble.
specific one too.
It's
Right.
The biggest issue with them is probably gastrointestinal, because obviously there's a slowing down of the GI tract, which is the intent of the drug to slow down your absorptive process. But that tends to lead to a lot of gastric problems. It's led to gallbladder problems. I mean, there's a rare case of pancreatitis, but these are not common. I think the issues would be gastrointestinal, and probably psycho-emotional, which is some sort of dependence on the drug to know that you have this, like, I can lose more weight if I need to lose more weight. So
Right.
it can create a little bit of a cycle in people. And I've seen this where they've lost
Dependency and
an excessive amount of weight or too much weight, and they're now underweight and they're afraid to give up the drug.
right. It's
So-
their crutch.
Well,
and what
it's not
about
really
with the
their
heart?
crutch.
Oh,
It's not really their crutch. I would say it's an obsessive, it's in a form of an eating disorder.
yes.
It's disordered eating where they can't
like a body
face,
dysmorphia thing.
yes.
Got
So
it.
they will go down to an underweight weight from, and maybe these are people that were, so if someone is
Like
overweight,
predisposed, right, going to do that anyway.
so that someone who's overweight, probably it's much harder for them to get to that weight. But someone who might be like minimally overweight, then perhaps they would be at underweight level, and then they're afraid to even go back to the middle ground.
Got it. And what about heart? How does it affect the hearts?
Current data is out on that. There's a one study that showed that congestive heart failure patients that were obese. So this is specific.
Right.
It's not for everyone.
Right.
Obese patients who had congestive heart failure had fewer hospitalizations after losing the weight from these drugs. That's the study. There's some studies on Alzheimer's with the oral medications that didn't really prevent Alzheimer's. So it's sort of, we don't know yet, but I think in general, if you get rid of overweight, you reduce your risk of diabetes,
Right, cancer.
diabetes, cancer. I mean, fat as it leads to cancer. So, I mean, everything is going to be beneficial from reduced weight.
So in staying healthy then, what's your thoughts on vitamins or supplements or diets? Are there fads like with fasting or?
I mean, I'm pretty conservative on my recommendations as a physician. I feel the only things I really recommend are vitamin D, vitamin C occasionally. I mean, you can take it. B12, iron if you're
So
deficient.
like a basic vitamin supplement is sufficient.
I'm not really big into vitamins to a level where I feel like people should be compulsively taking them. I usually base that on discretion with each patient.
Got it.
But D is probably the one thing that is beneficial for bone health as we get older.
Okay.
I think that's all. I think I made like a note. I was looking for that, but
Okay.
that's about it.
What do you wish your patients would start doing earlier in life to stay healthy mentally, physically, and emotionally? Both of you.
Socializing.
Okay.
Too many don't.
True.
Probably reduction in the phone use, obviously, is the no-brainer of this decade.
Correlates, yes.
Reduced alcohol consumption, trying to set some sort of social, I mean, if they're young enough, some social interaction that's not around alcohol or their phones.
Right.
That would be my thing. That's probably the most.
Let's all go out and craft together.
Yeah. Well, just actually,
No, I'm
though,
not
like,
kidding. I love it.
those things are
Right.
like engaging and
Right.
interactive.
Like
and
do your board games.
Yeah.
Even, like
yeah. And I think
The same thing we went back to before, exercising. That's a social thing. Can
right,
be doing
move
your
body.
puzzles, reading your books.
I personally and professionally think that every person should have a therapist. This is not touting Jamie's career, but
Go, Jamie.
I
Go,
think
Jamie.
that if everyone, I was very fortunate, and I'll shout her out, Dr. Nancy Kersner. She's been my therapist since I was 19, and she's gifted, and it really changed my whole perspective on how to deal with other people and myself.
Amazing.
And I'm very grateful for that. She's helped a lot of friends and family and people I've even, I've been actually very selective on who I send her because like I'm giving you the best. But
it's a secret prize.
yes, it is. And I think it's so wonderful to know that you have someone who could advocate for you and does care about you.
That's critical.
and someone who's objective.
critical.
But,
But
it's
also
also a
someone
really
who's-
good way to be accountable too.
Right.
Right.
And someone who's skilled.
Yes.
Because one of the things is people poll their friends and poll their, what should I do about this? But I'll tell you,
Right.
they don't really know.
No.
And
They can give good
I think
advice,
what you
but that
said is
doesn't mean
right.
that-
Both of you, someone who's skilled, who's an outside objective person who holds you accountable.
yeah, just
Yeah.
such a great thing.
Yeah.
It's a real,
Gift.
it's a gift.
It's a gift.
And I think that everyone needs to get sleep.
Yep.
And
Yeah.
that is to me
Healthy sleep.
Healthy sleep.
Right.
And
Which for some people can be 6 hours a night. I mean, it doesn't have to be,
Not me.
8 to 9 hours.
need
But I'm just
more.
saying,
You sleep
like
longer.
some people, but
I need a good 8.
some people, can really get less.
Yeah.
But it's the
but
quality.
notably, all those things lead into the same thing.
100%.
Because like if you're exercising, you're going to probably sleep better.
Mm-hmm.
If you're clearing your head of your stress, you're probably going to sleep better.
If you're eating well.
if you're eating well, you're going to not have GI problems.
Right.
Okay. If you go to bed and wake up in the middle of the night, but then you go and you're tired the next day, then you're going to think you're sick.
Right.
I mean, it just
They all
keeps-
go hand in hand.
Yes, it's a snowball effect. So I feel that's, and then I do think, last obviously, because there's a lot of, we didn't discuss a big piece of everything in Jamie's practice, which is family dynamics.
Oh,
And family dynamics really can alter in a positive or a negative way your whole existence, because that's really, and that's like starts in your nuclear family and beyond that. But if you have those other things and maybe learning about how to deal with that and accept your family dynamics, however they are, because they're all different.
or have no expectations
Well,
from them.
I don't know if you don't want no expectation. I don't think Jamie would agree with
No?
that. I think it would be adjusting your expectations.
What do you say?
Right.
Oh, adjusting. Okay.
Yeah.
And
Or learning what a
altering,
realistic expectation.
yeah,
Got it.
realistic
Therefore
expectations. Maybe there's some people with none, but I think that would be, I feel like you build these things from the center out.
Yeah.
And, and I think that's a very big part of in your personal growth. So when you get to a certain place, and that's why menopause sucks, because it happens when you're finally learning who everyone is and who you are. And
Menopause sucks.
then they make you gain 10 pounds and your hair falls out. And you're sweating all night and you can't sleep anyway. Just when you thought you knew what was good. And you were
Right.
liking your husband and having good sex, and now you can't. But other than that, I won't talk about the past
than that,
9 years.
it's so
there's
funny.
there's a workaround for that. So
All
Anyway.
right. So we talked about good, healthy habits for aging. What's the biggest myth that we need to know about aging?
that it makes you unhappy.
That it sucks. I was just going to say that
I
it
think
sucks. I think it doesn't have to.
I mean,
Yeah.
I wish I had fuller hair, and I think I might need to do my neck, and my skin on my legs is bad, but I feel like I know myself better now
Yeah.
than I ever knew myself.
Yeah.
And I think that, I'll try to do the behaviors to the best of my ability
Right.
to keep myself for longevity.
Yeah.
And so I'm there for my kids, and I'm still a productive citizen in our community.
Right.
But I really do feel that as you get older, you have that potential to really enjoy those things.
Oh, yeah.
So I'm feeling glad about that.
Yeah. I mean, I'm not the same that I was 50 years ago, but I wake up every morning with gratitude thinking, yay,
And
I'm
you're not
here.
the same as you were 10 years ago.
Or 5.
Right,
Yeah,
right.
exactly. But grateful that I get to age. I think that's what I feel like when okay, what's on the horizon? Cognitive, physical health, AI, different therapeutics, new diagnostic testing, new therapeutic treatments. What's on the horizon?
You want me to answer a little?
Sure.
Yeah, I want both of you to answer.
Well, with the age of the phones, social media, AI, there's a lot that is talked about now that didn't used to be, and that has its advantages and disadvantages.
I was going to say, do you think the information is a plus or a minus?
Both.
You mean like how every child thinks she has imposter syndrome, and
Right.
everyone has
Or-
imposter syndrome,
right.
everyone's
the
a
phrase
narcissist.
of the day or the diagnosis of the
and
month.
he's a narcissist, they're narcissists.
Right,
and
exactly.
Those are red flags.
Right, exactly. But I think there's a lot of alternative therapies that are getting more attention, and that's really cool.
Okay.
It's really cool for people to know that there's different options out there, that there's something that maybe they haven't heard of, something that's not as mainstream, but
Right,
it's
but
not
may work for
so
them.
off the beaten path that it's like, whoa. I think that's really cool. I do think in general, all of this information being much more at the forefront, I do think it's a good thing. I do think overall it's healthier, it's better. There's still so many people that, don't know about mental health, don't want to talk about it, don't know how to deal with it. Like there's still so many, but there's so many more that are much more open about it. So if you have a family of 5, if one person is more informed, then
knowledge is power.
That's a huge difference.
Yeah. I feel that in that capacity, more so because WebMD definitely ruined my life for a while. But I feel that the internet and our young people, although they have so much more anxiety and it's continual, and I don't know how that's going to really change, but I do feel that their language is different than ours, and they're
more savvy.
They're more inclined to recognize patterns and behavior, and they're more likely to. I'd like to differ with Jonathan Haidt on their anxiety. Haidt, however you say his name, but I feel that there's something about that that's very promising that they are able to access. I mean, the fact that they could understand AI and maybe utilize it in a way that's productive. Yeah. If they continue to engage socially, then that would be really amazing.
That's critical, I think.
Because I think I know quite a few people who should have known the term gaslighting in their life and they didn't. And my kids know that term.
Right.
So I feel like that's a good advantage.
I think that generation of our children is so much more savvy than we were at that same age.
Definitely. I think they need to even out some gender differences right now, because I do think that the young girls are much more adept at this, and probably the male the boys are they're facing it's not even further behind, but they're facing a lot more not necessarily demons online, but their access points are different. For the girls, there could be some really positive access points.
Okay.
For me, I could tell you quickly that the newest thing for us is going to be how AI shapes medical diagnosis, and probably will eliminate a lot of professions that are not needed. But I mean, you can plug a CAT scan into AI radiology and it will tell you exactly what's there. And I have to be honest, that's going to be really good for early diagnosis. Right now, it's still making errors, but I mean, it's going to really help because people are tired, they're not looking carefully, they're missing things. So I feel like in that capacity, I think it's going to help expand the way we take notes. We went to electronic records, and then the doctor's sitting there and doing all this stuff online. They can't even pay attention to the patient. Right. So with AI scribes, we're not going to need that. We're going to have someone dictate. It's going to be all for you, and they're going to give you the diagnosis like in your visit. Right. So it will be a little futurized eventually, but I think that's good. And I think that on the forefront also are some incredibly radical, great discoveries already have been in the fields of cancer. I mean, I watch Magic Johnson every day, and I mean, there's still good stuff happening out there. That man is alive. It was 1992. He came out as being HIV positive, and he has changed the world. Right. There's HIV PrEP. There's so many things that are really great. I think that there's some alternative treatments, like Jamie mentioned, that are going to be more accessible because people are asking for them. Right. I think that the idea that people can go, and this is a more socioeconomically restricted issue, but I think that people can go get scans of they can kind of circumvent bad medicine a little bit now, which is great. And I think that what would be really nice, and I don't know when that will happen, but we do need to still support some initiatives to help people who are more underprivileged access care. Yes. And that's critical. A political issue, but that's going to be a problem, I think, for disease burden. And I think that we have to really still promote vaccination. Oh, 100%. And a lot of that's become political, but it shouldn't be. But promote vaccination and certain healthful behaviors. I do agree that healthy eating is going to get us somewhere. Right. And I do agree that if we take pesticides out of things, we're going to probably improve our quality of life and quantity of life. But I still think that we need to practice some global health measures. Yeah. And they should be for prevention of disease at a global sense.
It affects all of us. It is a global situation.
But I mean, I think about the cancer paradigm since I've been in training. It is incredible to think that people are living with cancer for much, much longer. That's so hopeful. And that goes to a lot of diseases, heart disease. There's so many things that people are just surviving today. Yeah. And they're surviving, not incapacitated.
No, they're thriving.
So,
yeah.
Those are some things that are good.
Oh, good. Oh, well, everyone is maturing and each journey is unique. It's important not to compare yourself to anyone else. It's most important to be aware of your norms and know what works for you and to stay on top of your mental, physical, and emotional health with incredibly intelligent physicians and therapists like I've been fortunate enough to have in studio today. So the way, yes, yay, you girls. Before we sign off, I like to do something with everyone. It's called Quickie Questions. You in?
Sure.
Okay, good.
Sure.
How do you handle stress?
Dance.
I used to dance. That doesn't
I
happen.
know. It's not as much anymore. Walk. Right? It depends. It depends what it is.
Yeah.
There's different ways, but I think that
Dance is your
I think that's
go-to.
the answer, and that like there's having options.
Right.
Surprisingly, I've taken on homemaking a little bit for me in my older age. It's interesting.
Your older
But
age.
I feel like I never did those things before, but I cook and I like cleaning and I like taking care of my house and investing in my kids and sort of projects like that. Yeah. I never thought I would. It seems like home economics a little bit. Like I've completely
Sweeping
regressed
makes
to
me
that.
happy.
But I happen to like doing those things.
I do. I love to sweep. Sweeping is just
I don't
the
know. I just
silliest
feel
thing,
like
but
I
love
like
to do
I
it.
do not like to sweep.
Oh, I'll come sweep your
I
house.
like to entertain. I started liking to entertain and come up with creative ways to entertain, and that's a new.
That's
thing
a
for
good
me.
one. Okay, I like them both.
But I definitely don't sleep as well as I used to, and it's not helping that.
Oh, God.
Okay.
What experience changed your life?
My husband's cancer. I mean, that was probably the most life-changing thing for me.
I mean, I don't know. Moving here,
That's a big thing.
Experience. It's probably not the first answer I would think of, but yeah,
It's a big change.
yeah.
Okay.
Well, because I lived in two places. This would be the second. So
Yeah.
That's interesting, Jamie.
yeah.
Right. It's like my mom says that. She always says that's the pit thing that changed her life the
Well,
most.
I'll put it this way. I think it often, and more so now as I am getting older, in my previous life. And my previous life,
was
This was before you got here.
yeah,
was neat.
Yeah.
yeah.
True. What skill do you wish you had?
I feel like I said it recently, but I can't recall what it was. I wish I liked sweeping.
I'll come to your house.
I
I'll do
wish
it.
I
Don't
had
worry.
my husband's judgment, his steady judgment.
Good one.
I wish I was. It's a very it's like an incisor. It's just like exact.
Right.
But I mean,
I
a
definitely
physical skill I don't have. I don't know.
It could be any kind of skill.
I mean, I definitely at times wish I was more patient.
Mm-hmm.
It's funny.
Okay.
If you as impatient. What are you not
Ask my
patient?
husband and my kids, and they might say different.
You sense yourself not. That's an area maybe where you.
No, they could tell you where I could definitely be impatient.
That's funny.
Okay. So that's a skill. Okay. What do you look forward to as you age?
I don't know how much I look forward that much. I look forward to like an occasional trip or something, but I don't think that
You're more
far into
present.
the future. Yeah.
Yeah.
It's kind of funny to put this way, but slowing down a little bit.
Yeah.
I mean, yeah, I find I don't have as much energy, and I don't mean that in a bad way.
Right.
Like, I don't exhaust myself anymore.
Right. No, that's good.
So I'm happier not moving as fast all
Right.
the time.
Right.
And that's
That's a good thing.
nice. It's different, but it's nice.
Good. Oh, thank you guys. I'm so happy you were here today. I love and
Thank
adore
you.
you both.
Thank
and
you.
so I'm so grateful that you were here and I'm so happy we did this. And I hope everybody out there can listen and learn and call upon you too.
Thank you.
No,
Thank you for having
girls.
us.
Jamie, as you're slowing down, now,
So
you don't
honored.
want to attract more clients.
I was gonna say you might get some more phone calls. You might
Okay.
it might take a little bite into that slowing down. But
Okay.
thank you. I'm so grateful you guys were here and so appreciative. Really, it meant a lot
welcome.
to me, and I hope our listeners learned so much from this. And
Yeah, I
it's
hope so.
fabulous to have two incredible, intelligent, beautiful, dynamic women, and
Thank
to
you
know
so
that you're
much.
out there to help this whole population.
Thank you.
So yay. Thank you. Thank you.
Thank you.
To our listeners, thank you so much. So grateful you're here. Keep listening, keep learning, keep laughing, keep up with Beek on Being. Follow Beek on Being on Instagram for the latest. To share thoughts, ideas, suggestions, or nominate a guest, DM us. Want exclusive content, behind the scenes stories, and listener links? Subscribe. Listen to Beek on Being wherever you get your podcasts. All podcasts are automatically transcribed. Big shout out and a huge thank you to Stephen Chen at Penthouse Studios. Beek on Being was recorded at Penthouse Studios and is a proud member of the Penthouse Podcast Network. Yay!
So
You
cool.
survived. How did you think? What did you think? It was good?
Yeah.
Yeah?
That was great.
I thought it was amazing.